Hi, Dr. Ray here. I wanted to pick up where we had to leave off earlier today. Apologize for running out of time, but I don't want you to get shorted on information. It does take longer to do breakout rooms and in-class sessions that are active, and I'm sort of adjusting to that. But I think that it still has its benefits, and I'd be happy to give you learning modules in any way if you're like you want access to a lecture or you want access to a different kind of format. We can work with that too. Okay, so the next question in this session was to click on the part of the spinal cord that's involved with sensory function, and it gave you this picture here. And so here you can see the spinal cord in a developing fetus, embryo rather, and you can see that here is the skin overlying the neural tube and developing spinal cord. And so if this is the skin, then this is going to be the dorsal side, and the ventral side is going to be adjacent to this developing vertebral body. And so that kind of helps you get some orientation. So this is going to become the dorsal horn of the spinal cord, and this is going to become the ventral horn. So this is the alar plate, and here we have the basal plate. And so if I'm looking just for sensory function, then I'm going to look at the alar plate. It reminds me that A is afferent functions, and then you can use that for a long time to help you pretty much situate the dorsal aspect of the spinal cord and dorsal root ganglion to all be pivotal for the afferent functions of the nervous system. So here, that's where I'm going to click, one of these two. It doesn't matter which one. I have them both highlighted with hot spots to show you the right answer. The next one is choose the most appropriate caption for the image. So the first one, oh man, those look complicated. Yeah, they do look complicated, but at least I know they're sensory ganglia. So here what's highlighted is ganglia of the cranial nerves that are associated with certain function, and they are actually sensory ganglia here. The second question is, yikes, I hope I don't have to know these later, but they look part of the sympathetic chain. So the sympathetic chain contributes to some cranial nerves, and in the head and neck it also travels along blood vessels, and really doesn't contribute to actually a whole lot of cranial nerves itself, but it jumps aboard one of the branches of cranial nerve 7. So it gets a little complicated, but you don't have to know any of that right now. But these are definitely not ganglia of the sympathetic chain. Those are going to be in the thorax that are going to be alongside the vertebral bodies, and the neck area. You do have a couple cervical ganglia, but they are definitely not situated as the attachment to cranial nerves, and there's not 4 of them. So luckily you can cross that one off. And then the last one, I have no idea where they came from. I know they come from the neural tube. And so this one's not correct because the sensory ganglia are synonymous with dorsal root ganglia, and are also, the origin is going to be the same as sympathetic ganglions. They actually come from neural crest cells, so they don't come from the neural tube. So that's why this one's incorrect. This one's incorrect because it's not part of the sympathetic chain, and so even if the only thing you know is that they are attached to cranial nerves and they're sensory ganglia, the answer is A. And so this is, I don't really expect you to know this was just one slide, but I like to do little integrations, show you where you're going with information, and so that you can kind of situate why things are important. So this isn't the most important information, but it'll help show you where you're going to go with it and make sure you have more of an understanding of the nervous system structures. Okay. All right. The next question, the individual had a malformation in the dorsal roots at T4 spinal cord segment. Which functions would you expect to be diminished, and which embryologic structure was malformed? So the dorsal roots are going to be the peripheral processes that grew from dorsal root ganglion towards the spinal cord. So they didn't actually come out of the spinal cord, but they grew towards the spinal cord. And dorsal being on the dorsal side and all the structures and where they are coming from, these are going to be mainly or exclusively actually interested in afferent function. So I'm going to look for GSA and GVA, and they came from dorsal root ganglion, so they came from neural crest cells. So I'm going to go with C for my answer because other ones didn't actually have neural crest cells. This one has neural crest cells in it and GSA, but the GVA is also going to be included in dorsal roots, so that one's not correct. But that would be the other one that might be a really good distractor, and I would, certainly never give you a question this detailed on an exam to hold you having to differentiate whether you should include GVA. But as an anatomist, I'm helping you with cement your understanding of these structures, and the dorsal roots coming into the spinal cord are going to carry both GSA and GVA. That's how it gets to its final destination. In the thoracic region, for sure. Okay, which of the following structures are usually affected in spina bifida occulta? So spina bifida occulta is not going to have the meninges involved, and it's not going to have any nervous structures involved. And so the spinal cord is a nervous structure. No, these are not going to be involved. The meninge is going to be okay. It's really just going to affect the vertebral arch and not in some cases, and then the skin overlying the vertebral arch. So those would be the two that I would expect. Okay. Which of the following be found at L3 vertebral column? So this was a question that I put in there just to help cement the understanding that the newborn baby, when it's born, it's still growing, and so the spinal cord is going to end at L3, and so essentially now that end of the spinal cord is called the cauda equina, and essentially you just need to click what structures are accurate in here. And so are there going to be roots? Yes. Is there going to be a dorsal ganglion? Yes. Is there going to be dura mater? Yes. Cerebrospinal fluid? Sure. Is the spinal cord going to end there? Yes, because it's the cauda equina. It's going to be below that. I didn't mean to say cauda equina. I meant to say conus medullaris. My apologies. So the spinal cord is going to end the conus medullaris, so you know that now. And then is there a sympathetic chain at L3? There sure is. The sympathetic chain goes all the way up and goes all the way down the vertebral column. So no, there's not a lateral horn in the spinal cord, but there is a sympathetic chain. And so that's important to understand that concept, that it's going to go the full length of the vertebral column. Okay. So that was as far as I really wanted you to get, but I wanted us to get through all of that today. But that's okay, we didn't, because I love to talk with you all and give you extra information. But this is important information that you do need to know. Okay, so here's a clinical application called Clippophile syndrome, and this is where you get abnormal fusion and joining of cervical vertebra. And it is going to be present at birth as a congenital abnormality. Individuals may have a short neck and an appearance of a low hairline. They may not. I have seen some cases, I'm looking online at YouTube, and individuals with Clippophile syndrome, it might take a really long time for those individuals to be diagnosed. I have a friend with Clippophile syndrome, and she had no idea for a really long time. She had a lot of pain in her neck. And some headaches and range of motion loss, but she really didn't know for a majority of her life. You can have kind of chronic headaches and pain, and you can also get some spinal stenosis depending on the severity of the fusion. Here are some other pictures of a younger infant here, and then this is an exaggerated case of Clippophile that I found online. So if a patient, this is a made-up patient, has Clippophile syndrome with spinal, let's say they do have spinal stenosis on the ventral side of the spinal cord at C4. So now we're on the ventral side. What might be on the ventral side of the spinal cord that could be damaged? And so would there be neurons from the basal plate? Or the alar plate? Oh man, which one's on the ventral side again? Well, alar is afferent, that's dorsal, so that's gonna be basal. So yeah, sure, that could be. Okay, the ventral ramus, dorsal root ganglion. So just going through these structures here. The dorsal root ganglion is not on the same side. Then thinking about if you have spinal stenosis, so you have narrowing of the spinal cord due to the bony structures around it. Thinking about where is the ventral ramus at? Well, that's actually outside of the vertebral column, right? It splits once it exits, and so that might not be affected. Could ventral roots be affected? Yes, that's inside, and so this could be affected. The sympathetic chain is not around there, and the white rami communicante are outside, and probably not going to be affected. And so the correct answers, or let's in this make-believe case, are neurons from the basal plate and the ventral root. So this just to help you put together in your mind's eye what structures are in which areas, and see what you were thinking of. Another clinical application is a condition called hydrocephalus. Hydrocephalus can happen for several different reasons, and it's essentially just a blockage of cerebrospinal fluid, or it's the reduction in absorption of cerebrospinal fluid. So for some reason, we have too much cerebrospinal fluid, or we don't have appropriate flow. And so the ventricles in the brain enlarge, and it compresses, it squeezes the gray matter, which is on the outside of the brain, around, up against its bony encasement, which is the cranium, and it actually damages the gray matter, and the ventricles get really, really big in the cranium. And so those exaggerated case. So it can be obstructive. It's also called non-communicating, and that means what it sounds like. The ventricles can't communicate with each other. So ventricles get very big and exaggerated. You can see all this white cerebrospinal fluid, which the ventricles are very large, and this is what it's supposed to look like. Here's the ventricular system here, very small, and here it's super, super big. Okay, and this is an ultrasound view, and you can see these are supposed to be much smaller. You can't, this is a different frame of section, but these should be about the size of the width of this arrow, and they are exaggeratedly large, the lateral ventricles here. So for some reason, flow is obstructive, and so you get enlargement of the ventricles in the area where flow is supposed to go through, but it's obstructed. So then, depending on where it's blocked, you're going to get enlargement of the ventricular system that is upstream from the blockage. And then the other kind of hydrocephalus can be non-obstructive, or it's also called communicating. And this just means, and you can't really tell which one it is from necessarily just from looking at a medical image, but for some reason, the production of cerebrospinal fluid is more than the absorption of cerebrospinal fluid. And this causes the ventricular system to be engorged with cerebrospinal fluid, and it causes dilation of the ventricular system. And so a lot of tests have to be done to maybe see if there's a blockage and sort of determine whether or not the individual has a communicating or non-communicating hydrocephalus. And a lot of hydrocephalus can occur with age. So I know a lot of older friends of mine, not a whole lot of them, but some of them have a communicating hydrocephalus, and they have to have shunts put in just to make sure that they don't have increased intracranial pressure. So hydrocephalus is something that can occur and can happen in lots of different ways and for different reasons. So it's a condition that you want to be aware of. And then another condition is called Merencephaly. It used to be called anencephaly, which means without a cranium or without a brain, and but that's really not true. So Merencephaly is a more appropriate term because there is usually partial development of the brain and cranium. So here you can see the cranium failed to develop. You can see this brain sort of spilling out from the superior aspect of the cranium. And so the neurocranium, the actual house of the brain, it has to be induced by the underlying brain, and sort of it causes a reciprocal induction. So brain development is very closely attached to cranial development. And so you can see a lot of malformations and alterations in the cranium and the brain. And we'll do that when we get to brain development in the second year. And here you can see image here that where there's actually, you don't see much of any aspect of cranial development. And then I did give you this little cheat sheet. I think it's nice to have just sort of a summary, because I think what happens if you look at these categories and you don't understand why the answer there is synapse, or you don't understand why the answer is no synapse, it's a good checkpoint to go back and say, what have I gotten wrong about this? Because I didn't think this would be the definite answer for this category. And so I'd like to sort of share this with you, because the nervous system is difficult. That's why people like me, people who like difficult topics, you want to tackle them and you want to feel comfortable. And so what you have to do is keep throwing yourself questions and scenarios to see how well you're remembering the rules of the nervous system and how everything is laid out. And it does take a while to unfold. So I hope that you don't feel overwhelmed with it, but I remember feeling overwhelmed when I just started. So I'm here to help. We're all here to help you if you're having any trouble with the nervous system. I hope that you enjoyed this session on embryology, and especially neurulation, the spinal cord development. If you have any questions, Dr. Hill, Dr. Brandt, and myself, we are here and happy to help. Thank you.